Hello and welcome to this PCR webinar, Drug-Coated Balloons as a First Choice for Patients with de novo lesions, Pros and Cons. My name is Andreas Baumbach. I will moderate this session, and with me in the studio is Bruno Scheller, one of the pioneers of DCB, and we have live from Madrid, Xavier Escanet. You can participate, and it's important that you do so. You have the chat maybe in front of you, but you can log into it. We will ask a question, not now, but in a couple of moments. You should vote. The question is, DCB should be used routinely for native coronary artery stenosis. And it's going to be yes or no. We'll do that before the debate and after the debate to see whether what we've discussed changes anything that you think about it. Now, the history of drug-coated balloons is going back into the last century, really. It started with the idea that paclitaxel can inhibit smooth muscle cell proliferation. That came out of Tübingen, where my working group was. And then we went into a phase of local drug delivery, only then to find the first drug-coated balloons, and Bruno Scheller here was one of the first to experiment and then use them in humans. 2006, the first publication. CE marks came around 2014, after a long time of experimental work and research, and it has taken until 1st of March 2024 that we have an FDA approval for the indication of in-stent restenosis for drug-coated balloons. So, where are we now? The clinical practice is widely variable. We have people that use them for almost everything, and we have labs where no drug-coated balloons are left. The leave nothing behind mantra seems to come back. Indications that are sort of firmly backed by evidence could be in-stent restenosis, small vessels, high bleeding risk. We'll discuss that. The evidence is pro and con. There are cost implications, and there's a large range of DCB systems. These are the available, commercially available systems as of today. So this is a big field. We've created a series. Today, we will talk about native stenosis. And on the 29th of November, with a different team, we'll talk about in-stent restenosis. And on the 11th, we'll have a double whammy, 11th of December, that is, where we look at clinical practice pattern in Asia, in Europe, across the world, with case examples. This all is supported by an educational grant from Concept Medical. So the main aims are, we want to define the concept and mechanism of DCB. We want to summarize the key clinical studies supporting efficacy in native vessels and in-stent restenosis. That's for the series. Evaluate the advantages and limitations of DCB in practice. Analyze real-world cases. Review how in-stent restenosis occurs and how DCB can address it. And we want to discuss the effectiveness and evidence for DCB in managing also in-stent restenosis. Let's start with today's session, drug-coated balloons as a first choice for patients with de novo lesions. And we set this up as a debate between Bruno and Xavier. And Bruno will take the first, and he will be in favor. He's a protagonist of drug-coated balloon for the treatment of native coronary stenosis. This will be followed by Xavier Escanet, who will caution us against the routine use or too much use of DCB in clinical practice. And then it's your turn. Now is your turn. Now we want to know, what do you say? DCB should be used routinely for native coronary artery stenosis? Yes or no? The poll starts now. And we'll wait for the numbers to come in. And I will read them out, and then we'll go into the first part with the pro. Numbers are coming in. At the moment, we're at 50-50. This is like a poll we recently had. Turned out different. 59-41. We'll give it another minute. Okay, so this is the session. As I said, we will have those two, then we have a discussion. We will have questions from the audience, and we've got audience from across the world, and we'll try to answer those, and we'll finish by the end of this hour. So at the moment, we are 58 in favor and 42% no. So that's pretty nice starting point. Over to you, Bruno.
Thank you, Andreas. So I'm very happy that the initial poll is a little bit in favor of DCB. Why makes it sense to think about alternatives to drug-eluting stent in the treatment of coronary de novo disease? Because we know that beyond the first year, we have a device-related event rate in the range of 2 to 3%, independent of the technology we use. And so far, we have no indication that this yearly event rate stops at any point of time. And therefore, especially for younger patients, it makes a lot of sense to think about alternatives to drug-eluting stent. We created this concept of DCB almost 25 years ago. And the basic principle is that we coat conventional balloons with antiproliferative agents like paclitaxel or now sirolimus. But it's not enough to do the drug on the balloon surface. You need additives, we say excipients today, to guarantee that the drug is not washed out in the blood during the passage to the lesion, and that we have some support of drug transfer from the balloon surface to the vessel wall. And the next step is to keep the drug in the vessel wall. And the big advantage compared to stenting is that we have a very homogeneous drug distribution to the artery. The clinical application, the concept for the clinical application of DCB has been suggested by us in the DCB consensus group, and it's called DCB only. And DCB only means that you focus on lesion preparation. You do the very best you can to achieve an adequate lumen gain and to avoid flow-limiting dissections. And if you achieve this goal, then the recommendation is to only apply the drug locally with the DCB. If you do not reach those goals, then the recommendation is to use modern drug-eluting stents. So the concept is not either DCB or DES. It's a combination of both, depending on the result of your lesion preparation. Why can you leave dissections? Dissections are the mechanism of angioplasty, and we know from the beginning of angioplasty that there are different types of dissections, and we have benign dissections that are not flow limiting, and those have excellent outcomes with very low rates of acute or subacute closure. And this is, for example, data from the angiographic sub-study of the Basket-Small 2 trial, where we looked at the angiographic follow-up, and you can see that in the DCB group there was no single vessel closure, but in the drug-eluting stent group there were some clinically silent total occlusions of the stent. This shows that this concept is safe. What do we gain? We gain vasomotion. It is clear that in the stented area there is no vasomotion at all anymore. But what we also see is that in the distal part of the treated segment, we have better vasomotion with less vasoconstriction than it is in the areas beyond the drug-eluting stent. And the second thing we see is late lumen enlargement, especially with paclitaxel-coated balloons. This means that we have a shift in the MLD distribution from the index follow-up, typically beginning from 4 months after the procedure, from the left to the right. This means you can accept a non-stent-like result, like in this angiographic example, and you will have a better lumen over time. And the next very interesting thing is that we see some kind of regression of atherosclerosis in the treated area. We have seen in animal models that there's a stabilization of the plaques and a reduction of inflammation compared to conventional angioplasty when using paclitaxel-coated balloons. How do you do lesion preparation? This is an example from a 60-year-old male with this long diffuse lesion in the LAD. And what we did was first a lesion preparation with semi-compliant balloons. And the result is on the right. And you can see a long dissection with some staining of the contrast medium outside. And the distal part, a lumen gain that is not acceptable. So years ago, I would have directly stented it and with long stents, and the procedure would have been ended. But we have learned that we have new tools, for example, specialty balloons like scoring balloons, that allow us to modify dissections to make bad dissections into more friendly dissections. And that's the same what we did here. And you can see on the right that from this dissection that requires stenting, we converted it to a dissection that fulfilled the criteria of DCB only. And as a consequence, this long lesion was treated with 2 DCB, in total 5 centimeters length. How should we do DCB angioplasty? What is the role of imaging? We are a little bit afraid of doing imaging because the conversion rate to stenting may be higher. However, we have learned, for example, from this recently published trial from China, that if you are more aggressive guided by imaging, then you have reduction of late lumen loss and finally reduction in TLR rates. And so we have a new paradigm, a new axiom in interventional cardiology. For conventional angioplasty, it was the more you gain, the more you lose. For drug-coated balloons, we see now the more you gain, the more you get. This means dissections are not a bad thing. Dissections that are not flow limiting improve the outcome of your DCB procedure. What are now the potential indications? And here we go back to this large meta-analysis for drug-eluting stents. Drug-eluting stents have the very best outcomes in non-complex coronary artery disease, as you can see here. And this was exactly the indication for the REC-CAGE-3-1 trial, which has been recently published. And this trial was negative for the DCB. The event rate was higher in the DCB arm at 2 years than it was in the drug-eluting stents arm for this non-complex coronary artery disease. What is the explanation for this finding? Besides the indication, I think we have to look at the technology of the different DCBs we have. You can see here 3 PK curves up to 28 days for the same coating composition, paclitaxel plus the contrast medium iobromide, which was our initial approach. And on the left side, this work from Juan Granada's group shows that crystalline coating has a high persistence of the drug in the vessel wall during these times, whereas with the amorphous coating, you see a fast decline of the tissue levels. And on the right side, you see the PK curve of the Zweit DCB, which was used in the REC-CAGE-3-1 trial. And here again, you see a very sharp decline of the tissue concentration over 28 days. And that may explain why we see this loss of efficacy. In contrast, here you can see the PK curve up to 6 months. This is not only 28 days. For example, the paclitaxel urea coating, and you can see that up to 6 months here, we have therapeutic tissue levels of paclitaxel, and I think this will make a difference in clinical outcomes. If you go back to the REC-CAGE-3-1 trial, we have also seen that in the small vessel patients, the results between DCB and DS were very similar. The difference was in the larger vessels, and especially this separation of the curves beyond the first year, which is not typical what we have seen in other trials. Let's go now to the small vessel indication. This is the MACE rate of the Basket Small 2 trial up to 3 years, where the curves were very similar between drug-eluting stents and DCB-only treated patients. This was a little bit disappointing for us because we hoped to see a separation of the curves, but in this trial it was allowed to treat larger vessels too, and most of these large vessels in the same patients were treated with DES, so that we have a lot of noise in this event rate. However, if you look at patient level on all the trials with small vessel disease, here 1,475 patients, you can see that there is some benefit over time when using DCB and not implanting drug-eluting stents in small vessel disease. Another indication, now it's where the drug-eluting stents have not the best outcomes, is diabetes mellitus. And here again, the basket small 2 trial. The event curve in red are the diabetic patients that were treated with drug-eluting stents, whereas the diabetic patients treated with DCB had similar outcomes than the non-diabetic patients in both groups. And again, we have a recently published meta-analysis of 10 trials with 2,000 patients in diabetic patients. And here we see a mortality benefit for the use of DCB compared to drug-eluting stent implantation. Other data, longer-term data, for example, from Simon Ecclestone's group from UK, 5 years follow-up, show reduced all-cause mortality or a tendency to reduce all-cause mortality when using DCB compared to drug-eluting stents. Another interesting indication are patients with high bleeding risk, and here we have the randomized debit trial from Thomas Rizan comparing DCB only with bare metal stent implantation. Here was a significant benefit in MACE in favor of the DCB approach, but no difference in bleeding complications because both groups had the same regimen of antiplatelet therapy. Furthermore, there's more and more data supporting the use of DCB in acute coronary syndrome. On the left, the outcome of the PEPGAD and STEMI trial. On the right, the functional data from the Revelation trial in STEMI patients. A few weeks ago, the DCBIF trial was published from China. In this trial, first the main branch was treated with drug-eluting stent, then recrossed, and the side branch was either treated with a non-compliant balloon or with a drug-coated balloon. And here we see a significant difference in favor of the DCB approach. However, this had a lot to do with myocardial infarction, procedure-related and follow-up, which has to be discussed. In my opinion, this approach, this blended approach with first stenting the main branch and then doing the side branch with DCB is an interesting option, but my feeling is that a more puristic approach which clearly simplifies the bifurcation procedure with predilation of the side and the main branch and then using DCB in both branches sequentially may be a better option in the future, which will be investigated now in a large randomized trial. If you have smaller side branches, there's data that only treatment of the main branch is sufficient to keep the side branch ostium open. It is safe to use only DCB for de novo lesions. This is a meta-analysis of 26 randomized trials with more than 4,500 patients. And what you can see is that within the first year, there was a reduction of myocardial infarction with the DCB treatment, and that means that the risk for acute or subacute vessel closure is very low if you follow the rules of DCB only. What's the use of DCB in clinical reality? It's not an either-or. It's a hybrid or blended approach using DES and DCB, potentially in the future, again, BRS, in the same patient, depending on the lesion characteristics and the outcome of the lesion preparation. And this concept was investigated in this analysis from Korea, 500 patients with multi-vessel disease that were treated either with 100% stent implantation or with the DCB only approach that resulted in 2/3 DCB treated lesion and 1/3 DS treated lesions. And this hybrid approach was associated with a lower event rate at 2 years. Short word to sirolimus. We have not that much data so far. We have some mechanistic trials investigating different sirolimus-coated balloons. This is a paper from our group where we looked at treatment of de novo lesions. In ISR, we had very similar angiographic outcomes. Here in de novo disease, we see also good outcomes for the sirolimus-coated balloon, but this effect of late lumen enlargement seems to be more a paclitaxel-specific effect than a limus-specific effect. So my conclusion is that it makes sense to think about treatment of de novo lesions with DCB due to this stent-related event rate of 2 to 3% per year, and it increases with the number and length of stents we implant, so it makes sense to reduce exactly this approach. Lesion preparation is the first and most important step of the procedure, and we know that careful lesion preparation improves the outcomes of DCB and DES, and the decision between a DES and a DCB can be done on a per lesion basis according to the result of your lesion preparation. And what do we gain? We gain the benefit of late lumen enlargement. We have vasomotion, and hopefully that has to be shown on the long-term, no permanent implant-related complications. Thank you. That's my part.
Thank you very much, Bruno. That was the first part, clearly in favor of the use of routine use of drug-coated balloons in subsets, not in everybody, not at all cost, but in a hybrid approach and considering it for many, many patients. Now we hand over to Xavier Escanet, who will tell us that that might not be the best idea. Xavier.
Thank you very much, Andreas. I think it was an excellent presentation by Bruno. I enjoyed it very much. Now, well, I mean, obviously, I agree that drug-coated balloons are valuable components of the interventional toolbox. It's been development. They've been there for a long time. We use them a lot for the treatment of stent restenosis, and we also use it in certain subsets of patients with de novo lesions. Now, the point is that my particular concern is that DCBs are growingly proposed as a simpler and equally effective treatment for DS for the novo lesion scenarios. And if you look at the right, here you have a graph that was recently published reflecting the uptake in Japan of drug-coated balloons. And you can see that over the years is growingly increasing. And in the most recent year, 2021, it was about 21% of usage of all PCIs, PCIs in all patients. Now, why do we use coronary stents in de novo lesions? Well, the body of knowledge that supports the use of stents in coronary lesions is huge. I was trained as a plain old balloon angioplasty. I started my training in interventional cardio in 1987. So I went through the whole trip of using balloon angioplasty alone, and then the arrival of stents and then drug-eluting stents. So it was very, very important, disruptive. It was something that was called at a certain point the great equalizer, because it allowed the junior to achieve a result that was as good as the one obtained by the very experienced operator. And it actually set the standards to say that you have a very successful result whenever the patient leaves the hospital alive. I mean, I think that's what the drug-eluting, the stents achieved. In 2005, the guidelines of the ESC recommended stent as the PCI device, the default PCI device. And in 2019, you have this laconic sentence that says DES for any PCI. Now, the point is that since then, the technological developments in DES technology continue to improve. And it's interesting then to revisit the validity of concepts that were introduced in 2009, 2013, like vascular restoration therapy and leaving nothing behind, which emphasize deleterious aspects of caging the vessel with the stents. Now, my point of view, I want to bring to you the idea that leaving nothing behind is a misleading concept, because it is true that you leave these struts that you can see at the left of the screen, which represent, of course, a very small percentage of the plaque volume, less than 1%, made of thin struts, endothelialized and covered with a neointima, like you can see here. And thinking that you are leaving something behind is ignoring that actually, when you are doing drug-coated balloon treatment, you leave this huge amount of plaque, of chaos, which explains why in the long term these patients continue having events. So blaming the events, the continued increase in events in the long term to having the stent, and ignoring that these events are triggered by this huge amount of plaque, I think it's something that is very naive. In the same way, leaving nothing behind is a very misleading concept regarding acute results of PCI. This is what you leave behind when you extend the vessel, and this was a revolution because you seal the disrupted plaque to avoid acute vessel closure, and this is what you leave behind when you performed drug-coated balloon alone. Now, remember that drug-coated balloons, will not be used nowadays unless you have stents to bail out. It's as simple as that. What increases the safety using drug-coated balloons nowadays is first, having a very potent antiplatelet treatment, and second, having the possibility to bail out using a scaffold device that is the stents. Now, the whole concept of leaving nothing behind is not echoed or mirrored in clinical outcomes. And I'm coming back to the study that Bruno told us before, the REC cage-free 1 trial, where you can see that actually the rates of target vessel myocardial infarction are similar in the patients that were treated with drug-coated balloons or with stents. So there is no signal, and it's very difficult to find in meta-analysis. I invite you to visit, for example, the meta-analysis of Fernando Alfonso in JAHA, where you can see that actually you cannot see a signal saying, yes, whenever you are not leaving the stent, you have less thrombotic events in the vessel, less stent thrombosis, even when there is no stent left. But at the same time, you have this pronounced increase in target lesion revascularization, which of course is probably due to a less effective management of the lesion by the drug-coated balloons. So if I'm thinking now in what is the role of drug-coated balloons in treating de novo lesions, I have to consider what is the current state of the art of PCI in this particular subset. And I'm one of the co-investigators of the Syntax 2 trial, which basically was trying not to test one particular device, not to try to test a particular stent, not to try IBUS or IFR. It was trying to check what was the impact on our practice in a compendium of best practices. And I believe that the 2024 version of this strategy will be this one. First, making sure that you are setting the indication in predicting PCI effectiveness, which of course starts by establishing what causes ischemia, it is obstructive or non-obstructive, then outlining if you have an obstructive coronary artery disease phenotype that is focal or diffuse, then checking if this phenotype of obstructive disease is amenable with PCI or not. And once that you have checked that it is amenable, that you can treat it, move forward to IBUS and OCT guidance, managing patient and lesion complexity with all the different tools that you have in your toolbox, atherectomy, lithotripsy, of course, drug-coated balloons, CTO skills, etc. Assess the results and optimize the results of your PCI, and then, of course, perform a very good medical treatment. So how would that fit in this scheme, the drug-coated balloon? Well, I think like with any PCI device that we want to integrate into this scheme, we have to follow a checklist. We have to ask ourselves if it improves procedural success. That means if it addresses a procedural obstacle, an unmet need in PCI. Second is to check if it improves safety and efficacy. Third, if it decreases angular symptoms, because remember that in chronic coronary syndromes, we perform PCI to treat angular symptoms. Fourth, check if it improves prognosis. 5, check if there are valuable niche scenarios. Now, if you get a superiority result in all this, then you can consider we really need to have this tool as part of our armamentarium, so to speak, to treat PCI. In case of non-inferiority, it is probably not enough. You should consider if the contribution of the device contributes to simplify your procedures, or if it is cost effectiveness, if it is cost effective. So let's answer the first question. Do I expect that DCB will improve my procedural success? Well, personally, I'm not aware of any situation in which DCB is an indispensable tool to achieve procedural success. I may need a atherectomy if I'm not able to cross a heavily calcified vessel, lithotripsy. I may need a cover stent if I have a perforation, but I'm not aware of any situation where procedural success will be addressed by DCB. What about improving PCI efficacy and safety? Well, Bruno showed us before this Madhavan meta-analysis where you can see this improvement in results of stenting from bare metal stent, first generation drug-eluting stents and second generation drug-eluting stents. There is this continued increase, rate of events, which of course, as I mentioned before, I do not believe you can blame the stent for this. It's probably just a result of coronary artery disease, of what you really leave behind. What you leave behind is huge atherosclerosis. But on top of that, if you have a look actually to contemporary data of stents, you can see that this is much better. This is from the study published in JAMA Cardiology in 2019, where you can see that actually at 1 year, TLR was less than 2%, and from there onwards is around 1%, extremely low. And more importantly, all these studies, including the one that we were showing in JAMA, did not use routinely intracoronary imaging, which has now 1A indication in the clinical practice guidelines. So if you, instead of considering a new device, you consider in doing a better job, you have to learn that in complex PCI scenarios, the use of IBUS or OCT will decrease your target lesion failure, target lesion revascularization, stent thrombosis, target vessel myocardial infarction, cardiac death, and all-cause death by this huge magnitude, order of magnitude. Enormous impact. So a very important message. You want to improve your PCI results, perhaps what you need to do is not to consider an alternative to stents, but to perform proper stenting. I know that that implies a change in culture, and I know that that's much more difficult than buying a new device, but probably is much more important for our patients. Now, another topic that is typically mentioned is that the stent length is a big problem. Is it a really a big problem? In the IBUS XPL study, and also in Syntax 2, we found that actually it is not the problem, the length of the stent is not the problem, it's the fact that it is properly deployed. And for that, you need intracoronary imaging. So with a CPU recommendation of 1A for intracoronary imaging, it seems much more reasonable to use intracoronary imaging than abandoning a stent in favor of ECVs, in my view. So again, I have to emphasize these important aspects. I mean, when you are performing PCI, what is going to dictate the outcome of your patients is the synergic use of well-demonstrated best practices, which in many occasions are supported by clinical practice guidelines. This is the territory where, as physicians who practice evidence-based medicine, like to work. We need to have well-demonstrated tools implementing together, and not, of course, just to look for new solutions. New solutions are welcome whenever you are able to improve even better the current state of the art. Now, another aspect is, will DCB lead to better angina control? Well, for the time being, I could not find a single study supporting this. The concept of preserved vasomotion after drug-coated balloon that was mentioned by Bruno before, and that contribute to less symptoms is, from my point of view, wishful thinking. If you really have a look to what are the causes of persistent angina after PCI, which of course include a variety of things, including microvascular dysfunction, but very importantly, improper revascularization. Some of the scenarios for which DCB use is proposed are particularly challenging for PCI as a tool to control anginal symptoms. And I'm referring here particularly to diffuse coronary artery disease. This is a hot topic, as you know. Diffuse coronary artery disease gets reflected in a particular hemodynamic phenotype when you perform longitudinal vessel analysis with your pressure guide wire or with functional coronary angiography. And we know that those patients that have diffuse phenotype of coronary artery disease, PCI is associated with a persistence of angina of 52%. Now, Some authors suggest that the index that reflect this diffuse pattern, like the PPG index, the pressure pullback index, you should reconsider embarking into performing PCI, because this pattern of disease is probably not amenable with PCI. But what is even more important is that you should not expect that actually drug-coated balloons will be more effective than drug-eluting stents in treating this diffuse pattern of disease. So my concern is that an important part of contemporary practice, which is outlining the obstructive phenotype of disease and simulating PCI results, will be fraught if you are trying to use drug-coated balloons, because you cannot predict what is going to result. The results of your PCI with this approach. In this approach, you assume that you will be able to achieve a proper round lumen with capable of normalizing hemodynamics, and certainly that is not going to be the case in DCBs, particularly in diffuse coronary artery disease. Physiology can be useful, of course, for guiding DCB. I sympathize with the concept that this is important, although I believe that the FFR and IFR cutoffs are unclear. More importantly, some colleagues proposed using resting index like IFR or PDPA, and I'm very concerned about this because we know, and you can check the document from EAPCI regarding this particular topic, we know that in patients on whom you have performed prolonged balloon inflations during prolonged preparation, etc., the patient may no longer be in a resting state, may have reactive hyperemia, the patient may be nervous, may have had some angina, and therefore you have a risk of having a false positive with these resting indexes. And other colleagues suggest QFR and other image-based indices. I do not believe that you can apply this because these indexes were designed to assess circular lumen, characteristic of being stented, and not vessels that are full of dissections. Another aspect is, may DCB PCI improve prognosis? Well, in chronic coronary syndromes, as you know, the effect of PCI on survival is very limited, it's very slim, and it is limited to patients in whom you are revascularizing large areas of ischemic myocardium, typically because you are treating proximal segments of the vessels. Now, in these proximal segments, and it was already highlighted by Bruno, probably the benefits of DS surpass the potential benefits of DCB, including, for example, the fact that you have lots of elastic recoil in the left main compared with other segments of the vessels. So, how do we proceed about niche indications? Do we have any niche indications? Well, small vessel disease, I sympathize with this particular aspect because, you know, first of all, it's a well-known scenario where the performance of stenting is lower. But it is true that the evidence that we have from studies like Basket Small 2 and Picoletto 2 show a very high event in the DES arm. And importantly, these studies did not use IBUS or OCT to implant the stents, which of course will have contributed to much better outcome in the DES arm. The bifurcations, I also sympathize with this. You know, avoiding two-stent technique is something that we all try to do, and we know that it's much better in terms of outcomes in the long term. But still, we are getting now the first trials like the DCB BIF trial that you can see here. I still have some difficulties in understanding how is it possible that the benefit of DCB over non-compliant balloon found in this trial refers specifically to myocardial infarction and not to repeat revascularization. I don't understand why there was a higher incidence of myocardial infarction in the side branch, but in any case, you know, it's a trial, you have to respect it, and I'm sure that we will get more information in future trials. In high bleeding scenarios, growingly increasing in PCI due to the age, due to comorbidities of the patients that we treat. I think that is important. We can reduce the dependence of DAPT in case of bleeding, and it's true that probably the development of neointima is faster after DCB because you do not have the metal interference, and of course you are not having the metal thrombogenicity during the first month. But the caveats I find is that the evidence supporting this for the time being, the debut trial, is that there were no differences in bleeding at 1 month, and that the comparator was bare metal stent, which we no longer use in clinical practice. I guess that if the study would have been performed with drug-eluting stents, and particularly with short drug DAPT regimes that we use with these stents, the results could have been completely different. Remember that, for example, the Master DAPT trial shows these fantastic results in terms of reducing bleeding complications and not having thrombotic complications after only 1 month of DAPT in patients treated with contemporary DES. Diffuse disease, I already mentioned before about that, obviously very important. You don't want to perform full metal jacket in these patients. It is undesirable. But the caveats I see is that it is uncertain if actually DCB will be able to control angina symptoms in these patients for the reasons that I outlined before. I don't know anything about uncertain long-term safety. And in case of small vessels that you will not be able to treat with a conventional stent, the management in case of acute occlusion can be complex. In addition to that, if you have extensive diffuse vessel disease, the coronary reducer can be a good alternative to treat anginal symptoms. And finally, and perhaps should be the first, the patient. I think that this is an aspect that typically we do not speak about it, but as of today, the use of DCB in the novo lesions in a liberal fashion means moving out of guideline and standard practice territory. It means moving into uncharted territory. The operator should take note of this, and the patient should know about this. So during the consent discussions, I believe that patients should be informed on the fact that on this fact, and that also on the rationale why DCB has been selected as the drug of choice in the context of DES standard practice. Finally, I think that the operator should remember that deviating from standard PCI practices, like using DCB instead of DES in the novo lesions, may require a stronger justification in case that there are adverse outcomes. So thank you, and I hope that I'm looking forward to the discussion now.
Thank you very much, Xavi. That was excellent. I think we should move one slide and go to question time. Now we've heard pro, we've heard con, and of course we've given them these topics as a debate, so they assumed a bit of a role. Now it's time to lay the cards on the table, really, gentlemen. Bruno, what's your clinical practice? What do you do in practice, outside clinical trials, every day?
So we have really implemented this concept of DCB only in our daily work, and we train all our fellows with this concept since more than a decade. And this results in a ratio per lesion of about 50% DES, 50% DCB. If you look at lesion length, we have longer lesion lengths treated with DCB. But I think this supports this concept of this hybrid approach.
Wow.
Most of the patients have both in our lab. Many have only DS, others have only DCB.
Okay, so 50%, but very long experience with that. Javier, where do you sit in Madrid? How often will the balloon be used?
So obviously the main indication for us for DCBs is in stent restenosis. And you know that the clinical practice guidelines 2024 actually now suggest that drug-eluting stents are the choice, so to speak. This is what it says in the table of recommendations for the treatment of stent restenosis. But when you use intracoronary imaging to assessing stent restenosis, as it is also recommended in the clinical practice guidelines, then in many occasions you understand that what has caused stent failure is better treated with a drug-coated balloon than with a stent. I'm going to put you an example. Sometimes you find that a neointima is heavily calcific, and I think it is a rule of it is a no-brainer. The fact that if you place a new stent and you generate a sandwich of calcium between a layer of a stent, a sandwich of calcium layer of a stent, you are making nothing good for the patient.
Javier, let's
So that would, yeah.
native coronaries. Where is a place in your practice if there is no stent in there, but you
The most frequent scenario I would say is the side branch. When it is a significant size, side branch is an important one. Situations also with high bleeding risk, or situations where you anticipate that the patient may have surgery in the near future, is also an important clinical indication.
So I think that's where we match. So what we do in London, the younger doctors, they always use a drug-coating balloon almost in side branches when they do a bifurcation lesion. And there is use, and again, in-stent restenosis, of course, but in native coronaries, we use it, for this diffuse long LAD lesion where we don't want to do a full metal jacket. That's our indication, small vessels. So I think that's matching. We have, we've got a lot of audience and we have questions coming in, and I can summarize some of them, and probably that goes to Bruno. This is about lesion preparation. I wanted to ask you your protocol for lesion preparation. We can add on what's the role of high pressure in lesion preparation, and do you have experience with DCB after IVL?
Yeah.
So how do you prep? And then these questions.
So it depends on lesion characteristic. So if we have relatively simple soft lesion, I start usually with a screwing balloon because I can, with a high probability, avoid relevant dissections and have a good lumen gain. If we have some calcification, I start usually with a semi-compliant balloon to get some feeling how the
semi-compliant,
how the balloon behaves, but then followed by a non-compliant balloon or cutting balloon. In highly calcified lesions, we follow the typical protocols with rotational atherectomy and or IVL. And we have a nice series of cases meanwhile with IVL in calcified lesions followed by DCB. And this looks very, very promising. And my impression is, with only rotational atherectomy or especially balloons, you do not see this late lumen enlargement in calcified lesions after DCB. But if you do IVL, you create some channels for the drug to get in, and this looks very promising, but we need, of course, control data on this.
Okay. Then there is, I think, one I had for Javier, and that is, you made a very, very strong point about the use of IVUS and OCT, of image guidance for stenting. You created some of the evidence there. Would you make the point that you need to do IVUS or OCT, and which to actually assess a result that you achieve with a drug-coated balloon, or are we happy to go ahead, if we do it, also be happy with the angiographic result if it looks good?
I think that that what we have learned, and that's why the 1A indications are in the guidelines, is that intraocular imaging gives you lots of information on how to treat the stenosis, and not only on the result of stenting. We have less studies performed on the value on drug-coated balloons, but yet it is clear that the information you have in terms of selecting the size of the device that you're going to use, or the optimal balloon that you're going to use, understanding what is the substrate of stenosis, if you have calcium or not, that may escape your attention. All these things may contribute to a much better preparation of the plaque. I think that you should not overreact to the fact of dissections. It's something is important. There's a bit of schizophrenia about this, because some colleagues emphasize the importance of treating dissections when you have stents. But I think that not overreacting to this, you can get a very important information for guiding your procedure.
Thank you. So we've got a question, and there's several questions about this. Sherzad Ahmedov asks, calcified lesion, DCB or stenting? And then the second question is paclitaxel or sirolimus. So let's is there a role for DCB even if there is calcium?
If you get rid of the calcium, if you can crack it, yes, of
Okay.
course. If not, no.
Okay, second question, and that is from several of our audience. Is there a differential use, or is one better than the other? Are they all equal? Paclitaxel, sirolimus, different types.
So we have learned already from the paclitaxel DCB that not all are created equal. As shown in my presentation, we have differences in the persistence of the drug in the vessel wall. And on the other hand, we have different sirolimus technologies. Sirolimus requires a long persistence in the vessel wall because we have a reversible binding to the mTOR receptor complex. And we have very limited clinical data so far for it. So at this time point, in my opinion, paclitaxel remains the standard drug for drug-coated balloons. And we have to wait for the results of the larger ongoing trials.
Okay. That will be a theme as well. There's several trials. We'll come to that in a moment. There's about 5 questions about bifurcations. Maybe I can ask Xavi, what would be your protocol if you use DCB in a bifurcation lesion? Do we do a final kiss, and how do we do that?
Yeah, it's a very good point, and I must say that we do not use it routinely in every side branch that we see, but of course, I mean, you have sometimes a side branch get pinched, particularly also if you have some degree of plaque, is something that we consider. Experience we have is that sometimes you have to perform kissing a balloon to make sure that you negotiate properly the drug-coated balloon to the side branch. And yes, I mean, I must say that predominantly is what we do. I mean, we typically do a stenting of the main vessel, drug-coated balloon in the side branch.
Okay, maybe Bruno can chase this as well. And I know there's a study coming, so...
Yeah. So in my opinion, it's nice to have DCB in the side branch, but it will not really improve the outcomes of the patients. Especially if you recross a stent that you implanted before. As this was the strategy in the DCB BIF trial. We had long discussions with the European Bifurcation Club about an appropriate trial design, and we will start hopefully at the beginning of next year with a randomized trial, 750 patients, randomized either to provisional T-stenting or the puristic DCB-only approach, which means you do predilate the main branch, the side branch, do DCB side branch, DCB main branch, and that's it.
Okay.
And this will be a very interesting trial.
Okay, there is another one on duration on the antiplatelets, and we had that discussion before. So let's focus on high bleeding risk patients. I think we all agree in the concept of no stent and hence no dual antiplatelets is intriguing, but Xavier made a point that you can have 4 weeks of dual antiplatelets and then be done with it at lower risk than a longer duration. Xavier, what is the antiplatelet regime? That's one of the questions from the audience. If you do drug-coated balloon only, what is your antiplatelet regime? Do you need dual antiplatelet?
Well, I mean, I think it depends on the context. At this point, I believe that the recommendation we have in the clinical practice guidelines is to have 6 weeks. But I think that can be, obviously, the impression we are getting is that you can get it shorter. I think that the important aspect here is that the fact that you have before you a patient who is a high bleeding risk does not imply immediately that you need to think in a drug-coated balloon. For example, if I have someone who has an ostial left circumflex coronary artery stenosis, for example, imagine that with some calcium or whatever, as typically happens, I think that in these patients, I would be much more happy to cross over with a stent to the left main, achieve a very good result, proper position guided with imaging, and then I will be happy with 1 month. But I think that the result will be much more durable in the long time than with that coated balloon. So I think, but if it is the circumflex in the mid segment or in obtuse marginal, it might be a very good choice, in my opinion. So, but the point is, high bleeding risk is something that we really have to obtain a great intervention in order to reduce the dependence of DAPT, but does not imply immediately to think in drug cortisoners.
Okay, so we're already at the end here. We've discussed potential indications. We saw the variation in practice with a lot of experience. Very good results can be achieved. I put the question to you again, dear audience. In clinical practice, can we see the question again? It's there in the poll. There you go. DCB should be used routinely for native coronary artery stenosis. We're interested in the repeat. And whilst you do that, I asked the question to Bruno, what's on the horizon? Where do we go from here? Native coronaries, just the native and DCB. So a lot of trials out there, right?
Yeah. Some larger trials are running, like the Solution trial, more than 3,000 patients randomized, the Transform 2 trial. I mentioned already the EBC DCB trial, which will start. We have a large de novo trial, the reverse trial, running in Asia at the moment.
Okay.
We are planning Basket Be All, which
numbers are coming in.
Which will be also a strategy trial. And my point is that I think it makes not that much sense to compare one device with the other in one specific lesion. I think the future is to compare the strategy of treating everything with stents, or have this hybrid strategy to reduce the total amount of metal. And I think that's where the future trials should go for.
Thank you. And we have numbers in. Still moving. Okay, I think we'll stop here. Just 1% more. Good. It stands at 71% pro versus 29% no. So that means DCB should be used routinely for native coronary artery stenosis. At the beginning of our session, it was 58% in favor. Now we're 71% in favor. In England, we would say you won this debate. Congratulations, and never mind, Xavier. I think we all enjoyed your careful review of the situation, and I hope we all learned a lot about the current state of affairs for native coronary artery lesions. We also learned a bit about the balloon technology and the various drugs that are on there. We learned the concept that DCB have the potential to reduce the amount of stents put in, and intuitively that feels like something we should strive for, we should aim for. We learned that there are different drugs, and we should actually really look at the results of the individual devices rather than at all of them as one group. Some lesion subgroups emerge as indications, I think. High bleeding risk, maybe the bifurcations, the small vessels. Some others await more evidence. And finally, important trials are underway to further evaluate the role of DCB in native vessel disease. This concludes our webinar. Next time round, we will look in detail, 1 hour, into the indication drug-coated balloons for in-stent restenosis. You'll have this webinar available online on PCR Online for a long time. It was a pleasure hosting. Thanks for joining us, and goodbye wherever you are in this world. And I know we had a global audience today. Goodbye.